And as you already know by now, if you are already been in with this channel, that this is dedicated to the cause of community medicine. And this time we're very much in flow with the exam ready series. And this particular one is in continuation of the Explain Why series that I'm continuing, decoding the questions from the 10 years question bank and taking down in 2 parts. And this is the second part. And if you're new to this channel, so please go through this content. If you love it, please subscribe to the channel. It's completely free, and like, comment, share with your fellow friends so that they also are enriched by the academic content, and press the bell icon because that will let you know every time I put up an academic content and get you prepped up. So let's. In this section, I'm going to take up another bunch of very important explain whys, which is very commonly asked in your professional examination. That is third part 1. And let's take them one by one. The very first one is the primordial prevention best question again. The last one also I discussed certain questions based on primordial prevention, and this one also begins with primordial prevention, because remember, in community medicine, primordial prevention, or as for that matter, all the levels of prevention are of utmost importance. Actually, they form the base of community medicine. So the question runs, primordial prevention is the most important intervention in preventing non-communicable diseases. So let's look at the picture. Basically, non-communicable diseases, as you are knowing that is emerging as a big burden on the globe, and it kills almost 41 million people each year, which is equivalent to 71% of all deaths globally. Previously, it was the communicable disease burden which was affecting the globe, and now it is more and more the non-communicable diseases that is affecting the people in general. And the non-communicable diseases, primarily heart and lung diseases, cancers and diabetes, are the world's largest killers, with an estimated 38 million deaths annually. The non-communicable diseases are also known as chronic diseases because they tend to be of long duration and are a result of combination of genetic, physiological, environmental, as well as behavioral and lifestyle factors. So modifiable behaviors like tobacco use, lack of physical activity, the harmful use of alcohol, and unhealthy diets, which are completely modifiable, preventable, these all go to increase the risk of dying from a non-communicable disease. Prevention aims to prevent the onset of disease through risk reduction. So this is the basis of primordial prevention. It targets the underlying stage of natural disease by targeting the underlying social conditions that promote the disease onset. Hence, an important way to control the SCDs is primordial prevention that focus on reducing the risk factors associated with these diseases by addressing the emergence of the risk factor before the individual is actually exposed to it through health education and awareness and incidental behavioral change. The World Health Organization claims that reducing the global impact of risk factors, we can go a long way to reduce the number of deaths due to any form of NCD involvement. So let's have a look at this ischemic heart disease model and try to understand this question from the concept view as well. Because just as important it is to answer your question properly in your exam, it is also important to have the concept clear in your mind so that the question, even if it comes in different formats, you are able to explain it well. Now let's look at this pyramid of ischemic heart disease causation. So when we are managing the acute and chronic disease, which is clinically symptomatic, we are basically catering to the secondary prevention of it. And when we are saying we are improving the medical education for better treatment and better outcome, clinic-based risk factor control for smoking, hypertension, lipids and diabetes in those who are overt, that is primary prevention. But when we are tackling the social determinants of health, which indirectly contribute to the causation of the disease, such as poverty, illiteracy, urbanization, leading to overcrowding, pollution, mother and child nutrition being poor, and health in all policies approach, and as well as the healthcare financing and policies for smoking, regulations on this, alcohol consumption, trans fat consumption, more and more shift towards healthy food, increased physical activity, refrain from all pollution causing activities, as well as continuously improve the awareness and behavioral change. We are actually working at the primordial prevention, that is nipping the bud before it has blossomed, that is controlling the ischemic heart disease even when it is manifest. So that is how primordial prevention comes across as one of the best prevention modalities available for treating any form of non-communicable disease for that matter. Now let's come to a very conversant two terms, particularly given to this COVID pandemic since 2020 January. Quarantine and isolation are almost, part of your everyday dialogues. So while quarantine has become somewhat synonymous with stay-at-home orders, both quarantine and isolation refer to actions taken once there has been a known exposure to COVID-19. But let's see why they are not synonymous, although sometimes we use it interchangeably, which is not right. So let's see. Quarantine separates and restricts the movement of people who are exposed to disease to see if they are sick. In the case of COVID-19, this usually means that someone was in contact with a known COVID-19 case but is not yet showing symptoms themselves. This individual will stay at home and away from other outside of the immediate household for 14 days, which is the incubation period, following the known exposure or risky behavioral like travel. Whereas isolation is separating the sick people with the contagious disease from people who are not sick. So in the case of COVID-19, isolation usually means that the individual has been diagnosed with COVID-19 and is staying away from others, that is isolating himself or herself so as not to infect them. So in one case, it is an exposed individual kept in a separate place so that he is not infecting others in case he has been infected with it. And isolation is separating the known sick person who is already known infected from individuals who are not infected or not sick. So isolation tends to take place inside the home when the person is asymptomatic positive, whereas someone who has symptoms or has tested positive is isolated from the household members who have not. It is important to know that if household member, as in case of a COVID-19, that person should be isolated from others in the home and entire household should be in quarantine for 14 days. So for the infected person, the person is undergoing isolation. For the exposed person, the person is undergoing quarantine. So now let's get back to another very commonly asked question. Is BMI the best of all indices of obesity? And there is absolutely one very contradictory question asked about the same index. That is, BMI is not the only index for measuring obesity. Well, coming to BMI, well, as you all know, body mass is the simplest and most widely used parameter for measuring obesity. It is the epidemiological and clinical parameter used to define obesity in most of the studies. The body mass index, or BMI, as it's popularly known as, is calculated by dividing the body weight in kilograms by height in meters squared. So, BMI equal to kg per meter square. So, according to World Health Organization, a BMI of greater than or equal to 25 is classified as overweight, and a BMI of greater than or equal to 30 is classified as obese. But this is the World Health Organization classification, which was used globally. But due to certain, clinical trials which went on to show that the Asian population, particularly belonging to the Asia-Pacific region, they have tendencies of developing, other non-communicable diseases at a much lower cutoff value of BMI. And hence, it has been revised. That is, the criteria for this BMI classification has been revised for the Asia-Pacific region, and we'll discuss it shortly as we move on with this. And as I was discussing, the BMI is the most useful population level measure of overweight as well as obesity. It doesn't measure the body fat directly, and hence it is an indirect measure of obesity. The BMI correlates sufficiently well with the direct measure of total body fat to support its issues, which is evidence-based, and works as a public health tool for monitoring progress in dealing with obesity epidemic. And not only this public health tool comes across as very inexpensive and also an easy screening method for checking out weight or measuring the height. These are very basic things which even a layman can do. So categorizing into underweight, normal or healthy weight, overweight and obesity are commonly used. This is a gender independent and age independent once an adult. But when you're a child, the metabolic rate varies and the body surface area varies. So it is to a certain extent age and gender dependent as well, because the growth is different in the two genders. But once they become adult, it stabilizes, and then when you take the weight and height, it is usually gender independent and age independent. And the BMI appears to be as strongly correlated with various metabolic and disease outcome as are these more direct measures of body fatness, like cardiovascular diseases, respiratory diseases, reproductive system diseases, and many more. But a person's body fat composition changes with age. Just as when you are very young, the proportion, the growth rate are different. Similarly, as you age, the body fat composition changes. The percentage increases as one gets older. That is a fat percentage, which is not reflected by the weight and height. And body fat proportion varies, and that is not reflected in BMI, as we understand from this. A muscular person may not have much fat but have the same BMI as a person having higher fat percentage. Why is this so? Because the mass that comes across is similar. Let's look at this BMI chart and understand the difference between the classification as per the global standards previously set by World Health Organization, and which stands for the rest of the world, and the Asia Pacific standards. So as per the global standards, if you are less than 18.5, you're categorized as underweight. Between 18.5 to 24.9, it is normal. 25 to 29.9, you're overweight. 30 to 34.9, you're obese. And more than 35, you're extremely obese. So all this calculation is being based on weight in kg divided by the height in meter square. Whereas in the Asia Pacific one, the underweight category remains the same, that is less than 18.5. The normal category is 18.5 to 22.9. and overweight starts from 23 and continues till 24.9 and from 25 and beyond. It is classified as obesity as per the Asia Pacific standards. So that's how. A very common question found in your question bank is vitamin A supplementation and its role in measles infection. Well, vitamin A is a very important micronutrient and it is often referred as anti-inflammatory vitamin. Why? Because of its role in enhancing the immune function and regulation of cellular as well as humoral immune response in our body. It is not only important for the epithelial cell integrity, it is also important for the immune function of the mucosa. And it is a recognized risk factor for severe measles because this deficiency predisposes the children for development of measles, which has higher morbidity and higher mortality. The complications are more in these children with vitamin A deficiency having measles, and that is why the World Health Organization and UNICEF issued a joint statement recommending that vitamin A has to be administered to all children diagnosed with measles in communities where vitamin A deficiency is a recognized possible and where mortality related to measles is more than 1%. And the recommended regime is 1 lakh international unit by mouth at the time of diagnosis if the child is less than 12 months of age, and 2 lakh international units if the child is more than that. And continuing with the dosage of 2 lakh international units at intervals of 6 months till the child attains the age of 5 years. But when there is presence of ophthalmologic signs of vitamin A deficiency, such as night blindness, Bitot spot, which is a grayish-white deposit on the bulbar conjunctiva adjacent to the cornea, which in fact I've discussed in one of your problem cards, or xerophthalmia, the World Health Organization recommends the dose to be repeated in 24 hours and again 4 weeks later. Now let's come to a question related to hepatitis B. Hepatitis B vaccine in infants is rational. So let's find out why it is so. The most important reason for it is to prevent HPV infection early in life with the possible lifelong complications of chronic disease in the form of liver failure, liver carcinoma that affect so many who are infected at birth because of the vertical transmission or perinatal infection. And this can be chronic or even fatal in newborns. HPV transmission often occurring vertically from mother to child at birth and horizontally from an HPV infected adult or another child's infected body fluids to an unvaccinated baby or child. And the main benefit of the vaccine is its effectiveness. If the first dose of hepatitis B vaccine is given within the 24 hours of the baby's delivery, it is observed that 75 to 95% cases, it is effective in preventing the passage of hepatitis B from the mother to the baby. So for the best possible protection, the baby will need to complete the full series of vaccine. So now we understand that why, although it seems that hepatitis B is a sexually transmitted disease, then why we should give the vaccination to an infant who is just a little soul. This is the story behind it. Now, British counseling plays important role in HIV. Well, if you ever seen an ICTC in your medical college, that is where this pre-test counseling and post-test counseling takes place. And this pre-test counseling is actually the gateway to all the care, treatment and support the persons are in need of regarding HIV. The pre-test counseling caters to the informational, emotional and social needs of those attending this ICTCs, that is the integrated counseling and testing centers. The counselors, they need to be knowledgeable regarding this. They need to be acceptable, accessible and client oriented. That is, they should cater to the need of the client and maintain their confidentiality. Why so? Because due to any reason, the HIV AIDS is associated with a lot of social stigma in our country and even beyond. The main goal of the pretest counseling is to enable the individual to make good use of the test results, to assist those with negative test results to remain uninfected, and those who are positive to minimize the medical, social, and emotional impact of HIV on their own as well as the lives of their near and dear ones. The misinformation and extremely negative conceptualization of HIV/AIDS almost acts as a social and physical death even before the person meets the real death. And it increases the feelings of distress and helplessness and fosters denial and secrecy, which in turn poses grave risk to the health and well-being of seropositives and others, because a person is subjected to a lot of stigma which comes in the form of social judgment, anticipated stigma, internalized stigma inside that person, external stigma the person is subjected to, the discrimination with which he or she is dealt with in the society, and the resilience that we show towards them. So testing for HIV can put the patient through enormous stress and trauma. After having been provided with sufficient information to enable informed patient consent, all patients can opt out of being tested if they do not want the test to be performed. And all testing and counseling should be accompanied with the information on future transmission as well, so that the patient remains uninfected. Interactive, constructive information on HIV prevention and care can go a long way for preparing the community as a whole for effective living with HIV. Influenza pandemics are caused by influenza A and not by B or C. Let's try to understand this. First, let's understand the influenza virus as such. There are 4 types of influenza viruses: A, B, C, and D. The human influenza A and B viruses cause seasonal epidemics of diseases. Let's know a little bit more about the influenza A virus. That causes the pandemics majorly. The influenza virus A may undergo antigenic drift as well as antigenic shift. Antigenic shift is an abrupt major change in an influenza A virus resulting in a new heme agglutinin and neuraminidase protein in an influenza virus that infects the humans. And shift can result in a completely new subtype of influenza A in the humans because of this shift. It happens when influenza virus form an animal population gains the ability to infect the humans. Such animal origin viruses can contain a new hemagglutinin or a hemagglutinin neuraminidase combination that are novel in nature that most people do not have immunity to. So this novel exposure leads to a quicker spread. For example, in 2009, when the H1N1 virus with genes from North American swine, the Eurasian swine, humans and birds emerged to infect the peoples, and it spread very quickly, causing a pandemic. The influenza A virus undergoes both antigenic drift as well as the antigenic shift, and it is found in many species of birds and animals. Influenza viruses are divided into subtypes based on the 2 proteins on the surface of the virus, the hemagglutinin or H and neuraminidase or N. Hence, there are potentially 198 different influenza subtype combinations, although only 131 subtypes have been detected in nature. Whereas influenza B is typically only found in humans and change only by the more gradual process of antigenic drift. That is, there is no shift. Influenza type C, that causes very mild illness and are not thought to cause epidemics in human. And influenza D virus, it primarily affects the cattle and are not known to infect or cause illness in the humans. Hence, influenza A virus are the only influenza virus known to cause flu pandemics. So I hope it's clear to you all the story of antigenic drift and shift, and the major reason for all this pandemic caused by influenza A is its ability to shift. Now coming to a question related to HIV. HIV is a behavioral disease. So let us understand this disease to comment on it and explain. If you look at the different modes of transmission of HIV, you'll find that several behavioral factors affect its spread, directly as well as indirectly. So the prevalence of high-risk behaviors over time shows that the risk is increasing in the population. The unprotected sexual intercourse, anal intercourse, intercourse with adolescent women over 45 years are some of these high-risk behaviors. The behavior of breech population, which includes the truckers, the laborers, the tourists, and many more, are also important in spreading HIV/AIDS because sexually transmitted diseases, especially ulcerative ones, are predisposed to HIV/AIDS infection about 8 to 10 times more. Hence, this kind of behavioral activity leads to higher chance of HIV/AIDS infection. And it spreads more among the homosexual and bisexual men, judging by both HIV seroprevalence and that of the gonococcal proctitis. The other risk behaviors associated with HIV infection include the use of drugs, alcohol, tobacco, having multiple sex partners, and intravenous drug use with needle sharing, which all goes with the behavioral pattern of that particular individual. The blood transfusion recipients and the healthcare workers are also predisposed to risk. On the other hand, conditions related to safe behaviors, including knowing one's positive status of HIV, possessing skills of safe sex, perceiving one's risk accurately, and having the proper peer support in time is extremely crucial and provides a great support when needed. The health education is also, very enabling for the people to take life-saving choices in this regard, because behavioral change communication goes in a long way to make a reverse turn in all these activities, promiscuous activities mentioned. The preventive interventions are now our best defense, in fact, against this epidemic of HIV. And in fact, we often call that these preventive interventions are the best vaccine of HIV. But they require a clear understanding of the behavioral and mental health aspects of HIV infection and AIDS affected people. Now another HIV related question comes along. Hepatitis B infection is more dangerous than HIV infection. Now why would you say HIV infection and hepatitis B and compare and comment that hepatitis B is a more dangerous one? So let's understand hepatitis B at a greater length. If you look at the huge amount of community who are infected with hepatitis B, it's almost staggering. It infects people of all ages, and as many as 2.2 million in the United States itself are chronically infected, and the global picture is much higher. And up to 40% of the chronic infections may lead to cirrhosis of liver, liver failure, liver cancer, and which may lead to death. So the mortality is also considerably high. Hepatitis B is easily spread. It is 50 to 100 times more infectious than HIV, which is one of the major reasons for its easier spread, and can live outside the body for more than 7 days and still cause infection, which is again a cause of greater concern than HIV. And 2/3 of those living with chronic hepatitis B do not even know they are infected, but can still spread the virus to others through the carrier state, which is again a matter of concern. And In fact, many adults have increased risk of hepatitis B, like those suffering from diabetes, chronic liver disease, immigrant population, HIV infected people, multiple sexual partner, those people who are having it, IV drug users who are sharing their needles. So you can see different, a heterogeneous community are at risk of hepatitis B infection, and because of their higher infectivity, almost 50 to 100 times more infective than HIV, and the ability to persist in the environment for more than 7 days with 40% or higher chances of chronicity. These are the factors and affecting rate of all age group. These are the factors that go on to make hepatitis B infection a more dangerous one than HIV. Now coming to lung cancer. Lung cancer, the question goes, is considered as a largely preventable disease. Well, we usually say cancer is, not treatable and certain things like that. But the truth remains, lung cancer is actually a largely preventable disease. The primary prevention encompasses the elimination, a reduction of the exposure to recognized risk factors in a susceptible populations to prevent a disease. And this primary prevention is an important means to improve the public health and by far the most cost-effective and sustainable intervention for reducing the burden of cancer globally. Because you can always understand that when the thing has happened and you are doing the treatment, the chemotherapies, the surgical interventions and many more, that is way more expensive than stopping the exposure to the risk factors or quitting those factors which can lead to this development of lung cancer. So the primary prevention emerges as a way more cost-effective and sustainable intervention. In the lung cancer control, it is of great importance because one of the major factors associated with lung cancer, that is smoking. The smoking epidemic, if it is controlled through primary prevention, it can have a major effect on lung cancer because 80 to 90% of lung cancer are due to smoking. The tobacco through its various forms of exposure constitutes the main cause of cancer-related deaths worldwide among men and increasingly among women is also noted. The forms of exposure include active smoking, breathing secondhand tobacco smoke, passive or involuntary smoking, and smokeless tobacco as well. It's not that the tobacco which doesn't have smoke cannot lead to lung cancer. And the primary preventive measures can be in the form of public information and education. So if you're aware that yes, lung cancer may happen through smoking and you quit smoking, it has a great value to your health. The legislation and restrictive measures, that is the control of self-promotion, health warnings, restrictions on the cells, stopping smoking in public places, enforcing the existing Cigarette Act, smoking cessation activities, relieve the abstinence syndrome, avoid exposure to asbestos, radiation, rotation of workers to prevent development of lung cancer, national and international coordination, because a coordinated political as well as non-political approaches goes a long way in preventing this occurrence. So if you don't smoke, limit your sugar and salt intake, eat 5 portions of fruits and veggies a day, plenty of high fiber foods, get regular exercises and limit alcohol intake. These kind of primary preventive measures can go a long way to stop a disease like lung cancer from emergence. So now coming to another prevention related question. Majority of blindness can be prevented. Well, globally, it is 1 billion people have a near or distance vision impairment that could have been prevented or has yet to be addressed. The resolution on IPCE, that is Integrated People-Centered Eye Care, included the preventable blindness and vision impairment, and it was adopted at the 73rd World Health Assembly in 2020. The World Health Organization estimates that 80% of the visual loss is either preventable or curable with treatment. So this includes cataracts, onchocerciasis, trachoma, glaucoma, diabetic retinopathy, uncorrected refractive errors, and some cases of childhood blindness. The leading cause of vision impairment and blindness are basically uncorrected refractive errors and cataracts. So this avoidable blindness is basically the sum total of preventable or the curable blindness, and it is often referred to as avoidable blindness in total. To reduce the backlog of avoidable blindness through identification by initial assessment and treatment of curable blindness at primary, secondary and tertiary levels is done based on the assessment of the overall burden of visual impairment in the country. So what is basically done in this context, it would be good to know, that is develop and strengthen the strategy of NPCB, the National Program for Control of Blindness, for eye health for all and prevention of visual impairment. And in this mission of preventable blindness, cutle down, there is provision of comprehensive universal eye care services, quality service delivery, improvement of nutrition, treatment of infectious diseases, improvement of safety conditions, etc. So basically at the primary level, we deal with the management of acute conjunctivitis, ophthalmia neonatorum, trachoma, superficial foreign bodies, and many more. Secondary level, the management of cataract, trichiasis, entropion, ocular trauma, glaucoma, and tertiary care is for sophisticated eye care, retinal detachment management, corneal grafting, and specific programs addressing these care are the trachoma control program, school eye health services, VitaminA prophylaxis program, occupational eye health services, and there are several more long-term measures. So you can understand that with all these healthcare services, these mentioned different forms of eye problems leading to blindness can be largely prevented. Now coming to a very basic question of epidemiology related explain why. The terms source and reservoir are not always synonymous. So the starting point for the occurrence of a communicable disease, that there has to be reservoir or source of infection, from where it will all begin. And the source of infection is defined as the person, animal, object or substance from which an infectious agent passes or is disseminated to the host. Here the host is the immediate source. Now let's look at the reservoir. The reservoir is defined as any person, animal, arthropod, plant, soil or substance or even a combination of these in which an infectious agent normally lives and multiplies, on which it depends primarily for survival and where it reproduces itself in such a manner that it can be transmitted to a susceptible host. So the terms reservoir and source are not always synonymous. For example, in hookworm infection, the reservoir is man, but the source of infection is the contaminated soil full of infective larvae. Then let's look at the case of tetanus. The reservoir and source are here the same, that is soil. Thus the term source refers to the immediate source of infection and may or may not be part of the reservoir. Let's look at some more examples. If you look at tuberculosis, the reservoir is man, the source is sputum. HIV/AIDS, the reservoir is man again, and the source is body fluids or secretions. In malaria, the reservoir is again man or mosquito, but the source is infected blood. In rabies, the reservoir is dog or other animal, the source is saliva. In measles, the reservoir is man and the source is droplet. In Japanese encephalitis, the reservoir is pigs and birds and source is infected mosquitoes. The cholera has man as its reservoir and unsafe water and food as its source. And similar for typhoid. So let's come at a very important question, that is, epidemiologically carriers are more dangerous than cases. Apparently cases are the ones who are symptomatic. They are very ill, they may be admitted, they have clinically symptomatic and in distress, and apparently carriers are the healthier ones. But yet epidemiologically it is the carriers who are more dangerous than the cases. Let's see why. A carrier is a person or animal that harbors a specific infectious agent without the discernible clinical disease and serves as a potential source of infection. These carrier state may exist in an individual with an infection that is inapparent throughout its course. And usually this kind of carriers are known as healthy or asymptomatic carrier. During the incubation period, convalescence and post-convalescence of an individual with a clinically recognizable disease, commonly known as the incubatory or convalescent carrier. The carrier shed the disease agent and act as a source of infection to the susceptible individuals. Though they are less infectious than cases, their microbial load is much less. The carriers escape the recognition in the community due to the lack of overt clinical signs and symptoms, and they continue to spread the disease over a wide area and a longer period of time within the community without the knowledge of either the community or themselves. The classic example is that of Typhoid Mary spreading typhoid, who used to be a cook, and without her knowledge she went on to infect several people with typhoid whom she was cooking for. Hence, epidemiologically, they are more dangerous than cases who with apparent clinical signs and symptoms are diagnosed earlier and treated accordingly, and the community is also aware to stay away or take adequate protection because they are clinically overt. So hope this is of help to your examination which is coming ahead. Please like, share and subscribe. It's completely free, and hope this helps in your academic journey. All the very best for your examination. Happy studying.